So in donor oocytes, we have a couple of different options. You could use a known donor, or we could use an anonymous donor. Almost always we're using anonymous donors. We can usually use either a live donor, or we can go to an egg bank. Egg banks have become quite popular because of the fact that we can have a ready source of eggs right available, and there's less problems with matching because we have a lot more known characteristics of the donor, and then we can also purchase a whole set of oocytes and have multiple siblings from the same donor. So in summary, what I wanted to do was just to kind of give you a whirlwind tour of the evaluation of the infertile couple. All the speakers behind me are going to be more specific in dealing with each of these areas. It's always nice to be the first speaker because then you have everyone else behind you to help you out. You don't have to go into every little detail. But for the clinicians in the room that are generalists, we really want to have you consider referring patients to your reproductive specialist when you're, for the woman that's in ovulatory, after maybe 3 cycles of either clomiphene citrate or letrozole ovulation induction. Because after about that time, if you have normal fertility in a young woman, about 40 to 50% of the people should be pregnant. It would be reasonable to consider referring her even earlier than, let's say, 6 or 8 or 9 months of effort. Also, when you're doing an intrauterine insemination, if you're doing those in your office and the total motile count of the sperm is less than 5 million, we know that that's not as very successful, and those women are probably better served by doing in vitro fertilization. The IUI specimen that you're going to put in the uterus of an infertile couple should be at least 5 to 100 million sperm. So if you're at 5 million or 3 million, you're really at like the 3rd percentile. And then finally, when you have evidence of tubal disease or pelvic adhesions, you really need to probably think of those people as marginal for something like office therapy, and we should probably think about in vitro fertilization. And then finally, for those couples that have a history of spontaneous pregnancy losses, IVF and the use of pre-implantation genetic diagnosis has been a big boom for those patients, because some of those people may have, let's say, balanced translocations as well as other abnormalities. So I want to go ahead and close there. I want to thank you for being such a good audience. It's always a pleasure to come to Las Vegas to spend the weekend here. I'm sure we're all going to have a great time, and thanks again for inviting me.